Hi everyone, I'm Slade Carter. I'm the Deputy National Lead for Cardiovascular Disease Prevention at Public Health England, and today we're joined by Tracy Davis, Senior Project Manager, Primary Care, SNOMED CT Transition, and Denise Downs, Senior Terminology, Implementation and Education Specialist, both from NHS Digital, and they're going to be talking about from READ to SNOMED CT. The webinar session will take the form of a 20-minute presentation by the guest speakers and then a question and answer session at the end where everyone will get an opportunity to ask a question. So without further ado, please take it away. Thank you.
Thank you very much. So straight on to slide 2. So hopefully everybody has heard of SNOMED CT, which is probably why you're on this call. But just if people are unclear, just to start off with, what is SNOMED CT? We provide every supplier with, in effect, a dictionary that sits in electronic systems. And that has all the clinical phrases that those systems can use. We need everybody to use the same one, so we can do data extractions, etc. And everybody, if we use the word headache, everybody knows that that's what we're referring to. At the moment, we have 3 different vocabularies in use across the NHS, and that really is just not sustainable, and it causes extra burden for people. So SNOMED is the most up-to-date and the most comprehensive, so that's why we're moving everybody over to SNOMED. And in effect, this is what's going to replace the READ codes. Just as an extra piece of information, the dictionary, so DM&D, is already SNOMED, and that's been in use for quite a long while. So slide 3. So are they very different? Well, to an end user, if I tell you that one of those screens is SNOMED and the other one is READ, and you're reading it as a clinician, can you tell any difference? I would like to think that not much. Those eagle-eyed of you might spot that the one on the right has got some numbers in light grey, and you might have already heard that SNOMED is all numbered, so it's a slightly different code to the ones that you are used to seeing in READ. And so the one on the right is from a hospital, and that is SNOMED, and the one on the left is from a GP system, and that is READ. But if I'm reading it as a clinician, so colonoscopy, cholesterol level, to me, I can't really tell any difference. So most of the changes are in the background, which is why most of the work at the moment is being done by system suppliers. So slide 4. So as I said at the beginning, it's critical that we get everybody onto the same terminology, and SNOMED is the only one that can meet the needs, the business requirements of the NHS. We actually have 2 in primary care, and that's why GPs, when they get discharge summaries or messages from other GP practices, they often have to recode it. So that's work that they really, we would not want them to continue doing, and the move to SNOMED will remove that. And overall, if we can issue specifications, everybody's doing data extraction on the same terminology, and we've got the same one with hospitals and GPs. Over time, we're going to get much better data analysis, much better risk assessment, and overall, we should be able to improve patient care by having better knowledge. So slide 5, start getting down to some of the detail. So a notice, which is the standard way in the NHS that we inform people of things that they need to do, went out from the Department of Health. It went out in 2014. There's an extract from it. Because most of us are employed as arm's length bodies indirectly by the Department of Health, we actually have a legal requirement to comply with that notice. So as part of the changes in the 2012 Health and Social Care Act, we actually have an obligation, a legal requirement to comply with this notice. And basically, we are working hard to get general practice onto SNOMED. Now, the notice says for the 1st of April, it will be around the 1st of April, and I'll come into that in a bit more detail. So hopefully you are already aware that university was hired quite a long while ago, 1st of April 2016. We have been issuing no new codes.
Excuse me, sorry. Can I just ask people, if anybody's just joined the call, please do mute your phone and your Skype. So it may be a mute button on your phone or a mute button on your computer, or indeed *6 if you can't find a mute button on your iPhone. So just a reminder to anybody who's just joined, it is really important that you mute, because everything can be heard by more than 100 people. So please do mute your audio devices. Thank you.
So we're on slide 5. So as I say, excuse me, we're trying to get general practice onto SNOMED by 1st of April 2018. Read codes are already retired. You're not getting any new read codes. We know that for some of the things you request those on an annual basis, but the decision was taken by all the arm's length bodies in the room at the same time that we would take this move and live without codes for 2 years. CCV3 actually is used by hospital systems, and that's why it's got a slightly later date. If people aren't aware, that's the coding system used by System 1. Hospitals, slightly later date, mainly because they were less mature in their use of electronic records, but again, they need to be on SNOMED by 1st of April 2020. And that's part of the strategy to get everybody onto the same one. So slide 6. So some key information. We are very much trying to make this a transition. It is not a big bang where literally we flip a switch overnight and everything to do with read disappears from the systems. So what are the key things in that transition? Firstly, every read code that is already in a patient record will stay in that patient record. It will have alongside it a SNOMED code. The SNOMED code that goes with it, we have determined nationally, so that every supplier should do this in exactly the same way. We cannot guarantee, and we realised this very early on, we cannot switch every supplier to SNOMED at exactly the same time on exactly the same day. So as part of the transition, we have also provided for the SNOMED codes that currently have read equivalent, that when the system switches to SNOMED and users type in SNOMED, the system will also put a read code in alongside it in the patient record. And we call this dual coding. So that means that even though we've moved to SNOMED, for a period of time where we have a read code equivalent, we will be recording SNOMED and read. And that will allow some existing reports to keep on running even though they're expressed in read codes. So because of that dual coding, things like templates, protocols, even though they were written in read, will still be able to be run. And that was a critical part because we realised we could not move absolutely everything in an instance of time. We had to have this transition period. So if you look at the sort of the pink side, the dual coding we have asked every supplier to continue with until April 2020. That means that gives us 2 years. All the historical data, everything that has ever been recorded in read, and I'm telling you that is millions and millions and millions of items, the system suppliers have associated a SNOMED code alongside it. So if you write a new search in a year's time in SNOMED only, it can find your historical data that was captured in read. So suppliers at the moment, I have to say, this is not a trivial task for suppliers. I know we tend to criticise suppliers for not delivering on time, but I don't want to underestimate how big this is. They are heavily working on development. Obviously, we've hit some things that we've had to think about. So we're saying that the move to SNOMED will be around April the 1st, 2020. We know one supplier cannot do it overnight. It takes them about 2 months to roll out all the changes, and that's why that dual coding again is important. There will be some practices working in and entering SNOMED and still not transitioned, but this dual coding will allow us hopefully to keep everything working all right. So slide 7. So as I say, the transition will probably is around April 2018. The other thing that became very clear is things like QOF and enhanced services. April's an end of a financial year, so most practices, the feedback has been, you know, we would rather move shortly after April than just before. So MyQuest is a product that hasn't been updated for lots and lots of years, and actually NHS Digital moved it to be a legacy product probably about 3 years ago. It is still under the GP SOC framework, but a decision was taken that it was not appropriate to move that and redevelop it as a solution that could work with SNOMED. So we've got the dual coding in place. Under the current GP SOC framework, all the suppliers have to keep supporting MyQuest but written in Reed. And so under the GP SOC framework, which continues until December 2018, we've required suppliers to keep that product available. And as I say, dual coding of historical data is until April 2020. I'd like to put a caveat on that. If we issue or you start using codes in SNOMED that never had a Reed equivalent, we cannot dual code those. So once GPs decide, or once we start issuing new codes, we cannot dual code them. However, every practice has to deal with that now. We issue new Reed codes every year, and they have to work out which are the critical reports that have impacted, and they have to review and change those. I guess the only change this time is the potential for more codes is quite substantial now we've got SNOMED rather than just an update to Reed. So slide 8. So we have provided national maps. They're quite simple maps. It has a Reed code in it and a SNOMED equivalent, so it's a simple lookup table. They are designed that they just go from Reed to SNOMED. Part of the reason of that is we have things like duplicates in Reed, and they actually go to a single SNOMED concept. So you can't use them in reverse because you might find for one SNOMED code, what do you pick out of the 3 or 4 Reed codes that map to it? So for suppliers, we have also produced a map from a SNOMED code to a Reed code. We've agreed that with an expert reference group that was nominated from the Joint GPIT Committee, and the Joint GPIT Committee have signed off the approach that we're using. And we use things like what's the most popular code. So if a SNOMED code, we could get to it from 4 Reed codes, which is the most frequently used, and that's the Reed code that we use to map back to. We provide those, so if anybody wants them electronically, you can download them off our website, which is linked to on these slides. But if you just want to type in a Reed code and say, what does this go to in SNOMED, that yellow tile highlighted on our right-hand side on our resources website, browsers and mapping lookups, if you go there, there is a lookup from Reed 2 to SNOMED and from CTV3 to SNOMED. So you can actually look at them as an end user without doing anything about downloading tables or anything. So slide 9. So how do we think this is going to affect users? Data entry. Interestingly, the practices we have done some trials or some testing with actually finding new code pickers and the SNOMED quite intuitively, and actually think that that's going to be a minimum impact. And actually some people might just say, oh, my supplier's changed my screen slightly, and not even realise that they've gone from Read to SNOMED. There are some term differences though, so there are some of the old terms in Read, like engine in and NOS, that should never be used in a patient record, and they won't be able to find those. So we're trying to get those messages out quite wide that some terms will no longer be available. Searches, protocols, etc. is obviously the thing that is going to be most impacted, because as we start using codes that don't have a Read equivalent, they're going to have to be rewritten, because it's not clinically safe to just suddenly decide you needed this SNOMED term. We don't know whether it's part of your original criteria. All the national ones will be done by the suppliers, but we're getting a message far and wide to various people that they will need to rewrite some of their data extract specifications or their searches. If you're an organisation that's got your own data warehouse, then we are trying to encourage those organisations to get SNOMED in now. So that will be impacted. If you write SQL queries, they're going to have to be written for SNOMED. And the structure and the coding system in the background on SNOMED is very different to certainly Read 2, and it has some differences with CTV3. We do have technical guidance. We have a recording of how to do that, but that is where the biggest impact will going to be. So the biggest impact is on suppliers and those who provide data warehouses and services, less so on users. So slide 10, I'm going to pass over to my colleague Tracy Davis, who will walk you through the last set of slides. Tracy, we can't hear you.
So Tracy, can you just make sure that you've unmuted yourself? It might be that you need to press *6. Oh, there you are.
Hi, can you hear me now?
Yes, yes, yeah. Thank you, thanks.
Excellent, good. So I think the key thing that needs to be noted at this point is that this is a wider primary care issue. The impact, as Denise has said, is around primary care. Our delivery date being April 2018 and the secondary care delivery date being 2020. So just a little bit of background about NHS Digital and what our role is. It's a small team at NHS Digital whose key responsibilities is to look after the primary care programme and facilitate and support that implementation. Clearly that means working very closely with GP SOC system suppliers, so that's EMIS, Vision, Microtest and TPP, the four main clinical providers in primary care. We are also working though with subsidiary suppliers who may well be having systems that are integrated to those system suppliers, and some of those subsidiary suppliers may well be relevant to our NHS Health Check colleagues. So if, for example, you're using Apollo or Informatica, you may find that those suppliers are already fully aware of what's happening and have programs and plans in place to progress. And I'll come on to that a little bit further on the next few slides. The Sky notice is mandated through CCGs. So the relevance here for yourselves is that it's a wider primary care issue and it's programmed and focused through the CCGs, and we're working very closely with those to ensure that they've got relevant timely advice and guidance. And we have a key contact in every CCG who is the SNOMED lead, with whom any NHS Health Check folk should be able to work with. Okay, next slide please. Those CCGs that we've talked about, they are fully cited on the transition and they have signposted information available, and a little bit further on one of our slides goes through what that sort of extent of that communications is. It's important to note that the GPIT operating model has mandated this requirement, and that GPIT delivery partners, for example CSUs, are also being prepared, and there's training materials available for them and training for staff. What we do recognise is that because of the changes to the coding system and equally the changes to MyQuest, this is an absolutely ideal opportunity for housekeeping. So those people in primary care will be looking at their local reports specifically and their local templates and hopefully reviewing those. Anybody who's involved in primary care IT is aware of the huge number of reports and templates that sit on systems, many of which aren't used or which are old. So this is an opportunity to housekeep, to review those reports, to see which ones are critical and to see which ones therefore need to go into a new query language using the SNOMED coding. With regards to the data warehousing, that we would expect them also to be looking at their commissioned reporting and commissioned data analysis services and doing in effect the same sort of housekeeping. So this is quite a unique opportunity for primary care NHS to ensure that their reports are up to date. As I said, CCGs have provided NHS Digital with a point of contact, and I believe we're at 99% for that. So again, if you're interested in knowing who your CCG SNOMED lead is, please do get in touch and we can provide that information. Okay, can I have the next slide, please? Thank you. So Denise talked earlier on about the resources that we have. On the final slide of this presentation is a link to Delen. That's D-E-L-E-N. Delen is our resource site. And if you click on that link, it'll open at this page. And as you can see, there's a number of blocks. They are plans and roadmaps, fact sheets, data quality guidance, CCG and GP practice information, supplier requirements and technical information, and clinical guidance incorporating SNOMED CT. That will enable you to search that site, and it is quite extensive, and find the information that you want. And again, if you're unable to do so, there is an email address at the end of this presentation where you can query us and ask for information that you've not been able to find. Within there, we also have a query database where any questions that have been asked of us are recorded along with the answer and the date of that answer, because this is in some senses an evolving project, so the answer may be updated over time. So next slide, please. These are the sorts of communications that we're doing currently, and if you aren't aware or aren't keyed into any of these, I would suggest it would be a very good idea, if the change to SNOMED CT impacts on any data that you input or you receive, that you need to be signing up to these. So we have articles regularly in the NHS England and NHS Digital bulletins. We have articles in the CCG and GP bulletins. The Joint GPIT Committee have sent a letter to every practice and to all the local LMCs. We have a range of webinars about exploring SNOMED, designing searches, data quality, etc., all on Delen site. We've done presentations at national user group, conferences and regional events. We have a whole raft of resources. On the Delen site, we have dedicated resource areas for CCGs and Train the Trainer, where people can swap ideas and discuss and swap communications and literature. We have a raft of workshops that we're doing. Again, full details of those are on the Delen site. And if you're not desperately closely involved but just want to keep an eye on things, the monthly Snap update, which goes out to named CCG contacts, is a very good way just to keep an eye on what's happening and get the latest news. And again, your CCG contact will be able to provide that to you if you would like further information. Thank you. Next slide, please. One of the key areas is around quality and outcome frameworks, and this is an illustration of the approach. So NHS Health Checks relies on data specifications that are run in primary care and extract that data and return it to enable you to pick the cohorts or target the cohorts for recalling into treatment. With regards to QOF, which is similar in a data extract, we will be running QOF So the annual pull of the quality and outcome framework data will be pulled at the end of March 2018 using read codes. As we've gone live, April 2018, a year later, QOF will be pulled in March 2019, but it will only be pulled in SNOMED CT. The business rules team have produced a baseline of SNOMED CT in QOF, and suppliers are currently testing with this. The expectation, however, is the first extract of SNOMED CT will be in May, as we do a monthly pull just to keep an eye on the data and for other data extracts. So although the big one for primary care won't be pulled in completely in SNOMED until March 2019, after April 2018, we will increasingly start extracting data in SNOMED. Okay, if you want to take us on one, please, to slide 15. So let's focus a little bit on NHS health checks. What should NHS health check leads be planning now? Well, the key thing are gaining awareness, which clearly people are doing by attending this WebEx. As I've said, on our Dellen site, there is a vast variety of webinar sessions that you can book into. There are some really nice small webinars that are like 4 or 5 minutes, and it states next to them how long they are, so that you can do bite-sized chunks rather than having to sit and listen to a very long webinar. You need to gain some familiarity with SNOMED CT, so you need to be thinking about the data that you extract currently, and you need to probably be looking at Dellen, and you need to be looking at the mapping tables to see if you're pulling certain read codes, what would those SNOMED codes be? But most importantly, you need to be aware of how your health check queries are provided and how the data is returned. There is a mixed platform from the survey that Nikki and Slade did, looking at the ways in which NHS health checks was delivered across the patch. It's clear that there are multiple different ways. So there are, for example, those areas that have commercial software that manage this, for example, Apollo. There are those areas that use GP practice clinical system reporting tools. There are those areas that have a CSU provided query. Could you go back one, please? Could you take, thank you. There are those that use CSU provided queries. There are those where the local general practice, somebody within the practice, within the primary care healthcare team, actually has the query or develops the query. And we understand there's also folk in local authorities who are actually providing queries to some practices. The two things that local health check leads need to be aware of is who's doing it and how are they doing it. If their queries are written in MyQuest, then they will need to think about and have an action for moving forward. One of the key things as well is checking your current data quality. This goes back to the housekeeping. Over a period of time, you will need to transition your queries from READ or CBV3 to SNOMED. And this is a time to check your data quality. And again, on Dellen, we have details and support and guidance on how to do that. Next page, please. Slide 16. Okay, so summarising, the key thing here is to understand the timelines. SNOMED CT will impact on NHS health checks data items, but we will be dual coding probably until April 2020. The issue will arise for you when we are using new SNOMED codes that have no READ equivalent. If you are still running queries in READ and you haven't transitioned to your queries being in SNOMED CT. You need to understand the timelines of MyQuest end of life. The key point here is that MyQuest is currently contracted under the GP SOC framework, and as such, MyQuest will cease to be supported in that contract December 2018. We are aware that some of the clinical suppliers intend to run MyQuest for a longer period of time, but it will not be supported by NHS Digital, and our recommendation is you look to change your queries from MyQuest to a new query language. Going back to the previous slide where we discussed the different types of provider for NHS health checks, queries and reports, if you're using a commercial provider, you need to know that they have plans to migrate from Read and CTV to SNOMED CT. And you need to know, if they're using MyQuest for their query language, that they have plans to replace it. And most importantly, you need to know what their timelines are. So if that's a commercial provider, you ask them. If it's a CSU, presumably you're also contracted to them, commissioned with them, you could ask them. Your issues will arise if it's a local GP practice who is doing this, or somebody in a local authority who's writing the queries using MyQuest and issuing them to GP practices, because those are the folks that will need to address this themselves. Again, reinforcing the message, this is a CCG focused transition. What you need to know, particularly as a local authority NHS Health Checks Commissioner, is what is your CCG doing to transition to SNOMED CT, and how does NHS Health Checks fit into their plan? And if you need to replace your current process once you understand it, then you need to know what your requirements and what your options are for replacing that process. But again, I reiterate, understand the timelines. SNOMED CT will be live April 2018. We will continue to dual code till April 2020. MyQuest end of life December 2018, but likely to continue for a bit longer. You have plenty of time to do these last 3 bullet points here. Confirm how your NHS Health Checks works, understand what your CCG is doing, and understand your options. Okay, next slide, please. So that takes us through to any questions. Hopefully that's been interesting. The final slide, which Helen, if you could just show, please. That's got our details on, so NHS Digital, it's got inquiries, it's got the link to the Delham pages, and actually what it doesn't have, but which I'll make sure is supplied, is our particular SNOMED CT and primary care email account. So I'll have that email issued to make sure that any queries can be sent directly to us. Okay, hand that back to you, Slade, for any questions.
Thank you very much, Tracy, and thank you also, Denise, for a very insightful webinar on the transition from Read to SNOMED CT.